Hello guys, welcome back to my channel. In today's video we're going to be talking about two or only given anti-epileptic drug very useful in anesthesia practice. So I'm going to be talking about pregabalin, also known as Lyrica, and gabapentin, also known as neurontin. So what is their anesthesia indication? We're gonna get to that to the last part, but we need to understand first their mechanism of action. So these two drugs, because they have GABA in their name, please don't be fooled. They are only structurally related to GABA, but they don't have nothing else to do to GABA. They don't interfere with GABA metabolism, they don't enhance GABA, they don't bind on GABA, none of that. They actually bind on the calcium channel, T-type calcium channel in your brain, on the delta alpha 2 subunit. And this is how they inhibit the entry of calcium, decreasing your neuronal excitability and helping with seizures. So I did upload a video about the calcium channels blocker, and I did specify that calcium channels blocker binds to the alpha 1 subunit on the calcium channel voltage gated. But these anti-epileptic drug pregabalin and gabapentin, they're gonna bind on the T-type alpha 2 delta subunit calcium channel in your brain, decreasing your neuronal excitability. So for seizure, we use them for the partial seizure. We use them as an adjunct to treat the partial seizure, whether they are generalized or not generalized. So they also have a lot of non-seizure related indication, such like nerve pains. So we're going to use them in diabetic neuropathic pain and also in post-herpetic pain. So they have different kind of pain use indication as well. Now, why am I talking about these drugs together? Because they have a lot of similarity. So they are used for the same thing, they act on the same way, and even in anesthesia, we're going to use both of them in the same way. So let's talk about their metabolism. So they are very minimally metabolized. So they're gonna be excreted on change in your kidneys, in your urine. So if your patient has any kidney insufficiency, you really want to think of adjusting the dose. And also, pregabalin and gabapentin are low protein binding drugs. Good advantage, they will not have interaction with this high protein binding drug. They are not going to be able to displace the drugs that are high protein bind to increase their toxicity. So when I think about high protein drug in treating anti-epileptic high protein binding, I think about carbamazepine, phenytoin, valproic acid. So they are not going to increase their toxicity. And also, they will not increase the metabolism of oral contraceptive, so which is also great. And they will not displace other drugs like warfarin, anticoagulant, which are also high protein binding. So this is a great advantage for these two drugs. Also, in the liver, they are not CYP450 inducer or inhibitor. They are not UGT enzyme inducer or inhibitor. So you're going to have few interaction with those drugs that are CYP450 or UGT inhibitor or inducer, which is another great thing. So these drugs also main side effect is sedation. But again, you never want to abruptly discontinue them, because if you do so, your patient is going to have things like insomnia, weight gain, difficulty sleeping, things like that. So just be aware, you never want to abruptly discontinue them. So let's talk about the main point. Why do we use them in anesthesia? In anesthesia, you want to give them 2 hours before surgery. Why? Because giving them 2 hours before surgery. Remember, they are all only given drugs. So you give them 2 hours before surgery to decrease your opioid requirement. And by decreasing your opioid requirement, you give less dose of opioid for the same therapeutic effect, decreasing your toxicity to opioid, which is another great advantage and is the main reason why we use them in anesthesia. Also, they're going to decrease the early post-op pain. So after the operation, your patient, if you have given this drug 2 hours before surgery, your patient will have less pain after surgery. And they're also going to help with your post-op nausea and vomiting. So they're going to decrease the post-op risk of nausea and vomiting, reducing your risk of aspiration so you can extubate your patient safely. Now, there is no fixed dose on how much to give them 2 hours before surgery. Every provider has his own dose that works for him. I guess you just test the water and take your own dose and try. But these drugs are great drugs, and the only thing you want to watch out after you have given them 2 hours before surgery, your patient will have an increased sedation after operation, and for older adults, they might have delirium, and this is it. But in general, they have more advantage than disadvantages. So guys, if you like this video, please share, like, and subscribe if you haven't done so, and I will see you on my next videos. Thank you.